Hello students, welcome to the video. We are going to learn about the first stage of labor in this video. My name is Ruth Kesia. I am working as a tutor in M College of Nursing. The objectives of this video, you are going to learn about the definition of the labor, stages, causes of the onset of labor, physiology of the first stage of labor, mechanical factors which are contributing to the first stage of labor, initial assessment and diagnosis of the first stage of labor, the physical examination, nursing management, and the observations and how to record the progress of the first stage of labor, and how to record the fetal heart rate and amniotic fluid, how to assess the amniotic fluid, how to monitor the fetal distress, and active management of the first stage of labor. So these are the topics we are going to learn in this video. First, the definition. Labor is described as a process by which the fetus and the placenta and the membranes are expelled through the birth canal. So this is the definition of labor. The fetus, placenta and the membranes are expelled through the birth canal. Normal labor. So these are the criteria for a normal labor. It should occur at term. It should be spontaneous as onset. The labor should spontaneous in onset. We should not induce the pain. We should not cause any pain by giving any drugs or anything other, but rather the mother should have her labor pain in spontaneous onset. And the presentation, okay, the fetus presentation should be vertex. It means the head should come first. The process should be completed within 18 hours. The whole process, including the first, second, third, and the fourth stage of labor, should be completed within 18 hours, and no complication should be arising because this is the normal physiological process. Next, the stages of labor. So there are 4 stages of labor. The first stage, second stage, third and the fourth stage. We'll see the duration. In first stage, it is 12 hours in primary mother and 6 hours in multigravida. And the second stage, it is 2 hours, maximum 2 hours in primary mother and 30 minutes in multigravida. The third stage is 15 minutes in both primary and multi, and the fourth stage is 1 hour. Now we'll see what is the how we say when was the first stage has arrived. It means the first stage means it is the time period between the onset of true contraction till 10 centimeter dilatation of the cervix, otherwise full dilatation of the cervix. The second stage is starting from the 10 centimeter dilatation of the cervix till the delivery of the baby. The third stage starts from delivery of the baby till the delivery of the placenta. The fourth stage starts from the delivery of the placenta after 1 hour after the delivery of the placenta. So this is about the stages of labor. Now we'll see the first stage of labor. In first stage you have 2 phases. Okay. The first stage we said already, the duration of the first stage is 12 hours in primary. So in this 12 hours there are 2 phases, which is latent phase comes first and the active phase. The latent phase, the mother will have mild and short contractions. The cervix dilatation is 0 to 3 centimeter. In other words, till 4 centimeter we say it is a latent phase. In the active phase, the dilatation starts when the cervix is 4 centimeter dilatation, 4 centimeter dilated. The active phase will start. So that is the time when you start plotting this partogram. So the active phase starts when the cervix is 4 centimeter dilated, and the contraction, the pain for the mother during this phase will be moderate to strong contraction, whereas in latent phase it is only a mild contraction. And next comes the transition phase. So here there will be strong contraction. The cervix dilatation is from 7 centimeter to 10 centimeter. Now we'll see the signs and symptoms of labor. Okay, so lightening and frequency of maturation, spurious labor, cervical changes, premature rupture of membranes, bloody show, energy spurt and gastrointestinal upset. Okay, what is lightening? Lightening means the head of the fetus getting engaged into the pelvic ring. So when you measure the fundal height during third and the second trimester, it gets increasing, right? So till 38 weeks, the height of the fundus will be increasing till diaphragm. But after 38 weeks to 40 weeks, the head sinks into the pelvic rim. Because of that, the height of the fundus will come down from 38 to 40 weeks. It means the diaphragm will be free, and it means the mother will breathe normally. Okay, before she may have such a shortness of breath and breathing difficulty will be there, because the diaphragm pressing this fundus of the uterus pressing onto the diaphragm, and the diaphragm pressing onto this lungs of the mother. So now the lightening frees up the space below the diaphragm. So that is called lightening. And next, the frequency of maturation. So because the head of the baby is pressing onto the bladder, the mother will have frequency of maturation. Next is spurious labor. Spurious labor means false labor, in other words called. Okay, the mother will have painful, very painful uterine contractions, similarly like the labor, but there will not be any cervical dilatation and effacement. So that is called spurious labor or false labor, which may arise before the true onset of contraction. So that is also one of the sign. And the cervical changes. So you already know the cervical changes, how the cervix will be, how we feel the cervix when you do a vaginal examination. It will be very, very soft. Okay, and premature rupture of membrane. So this can happen because of the bulging of membranes into the cervix. Next is the bloody show. So this is caused by the mucus plug which is there in the cervix during the pregnancy, which is protecting the content of the uterus, so that the blood along with the mucus will come through the vagina, which is called as the bloody show. And next is the energy spurt. This is nothing but, you know, the mother will be tired throughout the pregnancy for 3 trimester. It means the 9 months the mother will be very, very tired, but one day in the morning she will get up and do all her household activities, and she will have all the energies to do everything. It is nothing but the nature itself give her the energy to do, to face the upcoming labor, to face the, to have a good energy for her labor. Okay, so that is called the energy spurt. And next is the gastrointestinal. So mother and gastrointestinal upset, the mother can have vomiting or constipation can arise. So these are the signs and symptoms of labor. So this is lightening, as I told you. So you can see the fundus of the uterus is hitting onto the diaphragm in the first picture, but whereas here it is free, right? The diaphragm and the fundus of the uterus is not touching each other. So this is called the lightening. And next we'll see about the causes of onset of labor, uterine distension theory, oxytocin stimulation theory. So these are some of the hormones which are responsible for the onset of labor. So oxytocin, prostaglandin, progesterone, estrogen and fetal cortisol. So these are the hormones. So first is the uterine distension theory. Here the overstretching of the muscle, okay, it promotes excitability of the muscles, so thereby leading to the labor. Next is the oxytocin. What the oxytocin will cause? It will inhibit the calcium binding to the sacroplasmic reticulum and increasing in the intracellular calcium. So you know already the calcium is the only ion which is responsible for the contraction of the muscles. Otherwise, the working of the muscle. Okay, so this oxytocin will inhibit the calcium to be binding. Okay, it means the free moving calcium will be there, increasing into the bloodstream. So this will cause myometrial contraction. And the sensitivity of the oxytocin to myometrium increases in the late pregnancy due to increase in number of oxytocin receptors. Oxytocin promotes release of prostaglandin. So prostaglandin is one of the drug which causes contraction of the myometrium, which causes pain for the mother. Okay, so the oxytocin promotes release of prostaglandins, and that will also lead to labor. Next is prostaglandin stimulation theory. Here what happens, the prostaglandins may diffuse to myometrium and initiate labor. And the progesterone withdrawal theory, we all know that progesterone is the hormone which relaxes everything during the pregnancy. So this withdrawal means it automatically causes the other effect, right? The progesterone level comes down. So because of that, the calcium binds the calcium to the sacroplasmic reticulum, decrease the intracellular calcium level. Okay, so that causes labor. And estrogen stimulation theory increases the release of oxytocin from maternal pituitary and promotes synthesis of receptors for oxytocin. So this also one way it leads to the oxytocin stimulation. Oxytocin promotes the synthesis of receptors for oxytocin. So more amount of receptors, it means that more amount of release of oxytocin. Okay, so that was done by the estrogen. And next is the fetal-placental contribution, activation of hypothalamo-pituitary axis. So, because of the increased release of ACTH, fetal adrenals, increased cortisol secretion, accelerated production of estrogen and prostaglandins from the placenta and the contractile system of the myometrium. It is nothing but the fetal adrenals will secrete the cortisol secretion. So this cortisol, what it does, it accelerates the production of estrogen prostaglandins. Okay, so from the placenta here, so the placenta also releases estrogen and prostaglandins, and that causes the contraction of the myometrium, and that leads to the labor. Next is the physiology of the first stage of labor. So what are the normal physiological changes happening in the uterus? First is uterine action. Under that we have fundal dominance, polarity, contraction and retraction, formation of upper and the lower segment, retraction ring, cervical effacement, cervical dilatation and ripening of the cervix. So we'll see this one by one. So first is the fundal dominance. As you see in the picture, the red area, so the red shade indicates the pain area. So where is the red shade? It is on the one end of the cornua. In other words, it is on the left side of the cornua of the uterus. So from there we say the pain starts. Okay, and from the cornua it spreads throughout the fundus and it goes down. Okay, so that's how the pain radiates throughout the uterus, and because it starts from the fundus, we say it is fundal dominance. Next is the contraction and retraction. So as you see in the picture, this is the muscle fiber of the uterus. This is the myometrium. Okay, so first picture indicates it is full length. Next, because of the contraction, it means the mother is having pain here in the next figure, so it is contracted. So during the third picture represents the relaxation. Okay, but if you compare the first and the third, it is not fully relaxed, right? Because the muscle fiber is not as same in the first picture when you compare with the third. Some of the contraction is retained in the muscle fiber, so that is called as retracted. So when the uterus muscle contracts and relaxes, this completely it will not relax. Some of the contraction is retained, which is called as retraction, and that's how the uterus will empty its content. It will send its content out of the uterus through the cervix and the vagina. So that is called contraction and retraction. So this is about only one pain I told. So what happens if the pain comes regularly? Okay, so much of contractions, and the muscles will be retaining the contraction. So progressive contractions will cause the emptying of the uterine content. Next is the retraction ring. So as you see in the picture, it is a ring, a physiological ring, which appear between the upper and the lower segment. Groove-like structure, it appears mainly on the neck of the fetus. But as you see, this retraction ring should go higher and higher. It means the upper segment will contract and retract, but the lower segment will dilate and distend. Okay, so that is called the retraction ring. It is a groove between the upper and the lower segment. While the upper segment becomes thicker and thicker, the lower segment becomes thinner to accommodate the fetus. Okay, so that is called the retraction ring. So this is cervical effacement. As you see, the length of the cervix, which is projecting into the vagina, the length of the cervix normally it is 35 millimeter. But you see the second picture, it is less than 5 millimeter. So that is called effacement. It means the cervix is taken up into the lower segment of the uterus. It merges with the lower segment of the uterus. That is called cervical effacement. And we measure it with the percentage. Okay. Next is the dilatation. So this is the dilatation of the cervix. As you see from A, B, C, A to E, the dilatation of the cervix, the space between the cervix, okay, space between the os, okay, external os is increasing, okay, to accommodate the coming head, okay, after coming head. So this is called the cervical dilatation. The first centimeter, the cervical length of the cervical canal is 4 centimeter, and the second picture, the length is 2 centimeter. The cervix is third picture, cervix is fully effaced. The fourth picture, it is 3 centimeter dilated. After complete effacement, it is getting dilatation here 3 centimeter. In the fifth picture, it is almost complete, which is 8 centimeter dilated. So this is about the physiological factors in the first stage of labor. Okay, so next we'll see the mechanical factors which are contributing for the labor. Okay, so first is the formation of water, general fluid pressure, rupture of membranes, fetal axis pressure, descent of presenting part. So this is the general fluid pressure. So because of the contraction, all the fluids tend to go down. Okay. So because the contraction and the gravity, all the fluids which are forewaters as well as the hindwaters will tend to go out of the cervix. Okay. That is called the general fluid pressure. Next is the fetal axis pressure, and because of the contraction and the gravity, the pain starts from above to downwards. It means the pain starts from carnua and spreads all over the fundus and then comes to the lower uterine segment. So it is always from up to down. Okay, so the fetal axis pressure is a longitudinal pressure from up to down. Next is about the descent of the presenting part. As you see, a line is drawn between the two ischial spine. So from there we calculate the presenting part, whether it is above the ischial spine or below the ischial spine. If it is above the ischial spine, it may be from -1 to -5. If it is below the ischial spine, it can be from +1 to +4. If it is +4 and 5, it is almost out of the perineum. So that is about the mechanical factors which are contributing to the labor. Next we'll see about the factors influencing labor. So these are some of the factors which influence labor. So because of this, the labor can get prolonged or the labor can finish up quickly. Okay, so these are the contributing factors. They are passageway, passenger, power, position and psychological response. So these are the 5 P's. Passageway means it represents the mother's pelvis. Okay, mother's pelvis, mother's cervix, the vagina and the uterus also. So that is the passageway. Who is the passenger here? It is the fetus and the placenta. And the passageway. So let's see the passageway. How does it contribute to labor? The passageway should be dilated enough. It should be big enough. The outlet should be wide enough to accommodate the big head. Okay, to accommodate the head. Okay. So that is about the passageway. Next is the passenger. So which is a fetus and the placenta. This is also contribute to labor because the passenger presentation should be vertex and also the position should be left occipital anterior, which is only the normal position, and the other positions are all abnormal and other presentations are also abnormal. The presentation can be face or brow or knee or breech. So this will also contribute to the duration, because if the head, okay, which is get engaged into the pelvis frame, the pressure of the fetus over the cervix will be firm. Okay, it will be firm on all sides of the cervix. It means the cervix is round, right? So throughout this round, the pressure will be firm and equal because of the fetal axis pressure and the membranes and because of contractions. But if you imagine the same pressure with the face or the same pressure with the brow or a knee, so you can say the pressure will not be equal on all sides of the cervix, right? So that will not the cervix will not dilate and efface properly and regularly as it does in the face and the vertex in the vertex presentation. So the passenger also contribute to the labor progress. And on the power. Power refers to the contraction system of the uterus. So that should be adequate enough. How much is the normal contraction means for every 10 minutes the contraction should be 3 to 5 contractions, and the duration of the contraction should be at least 40 seconds. So for every 10 minutes 3 to 5 contraction with 40 seconds is a normal contraction. But anything less than that, then we say that the contraction is not adequate. In that time you have to induce, you have to start with the oral infusion along with the oxytocin drip. And next is the position of the mother. The position also important, because in some positions the bladder may become full, and a full bladder will obstruct the second stage of labor. And in some position, because of gravity, that will facilitate the head to come fast. So the position is also important. Next is psychological response. So if you take a gravida, she has already faced this kind of labor pains, right? So she will respond normally. In other words, she will cooperate with you. But if you see in a primary gravida, she will have anxiety and stress, and she will not listen to your command, listen to your words, or she will not cooperate with the delivery process. And next is the assessment. So this is about the physiologic factors, mechanical factors, and the contributing factors. And next comes the assessment, diagnosis, and management. So what is an assessment? What all you have to assess? You have to assess the age, gravida, para, time of onset of uterine contraction. So the onset can be in hospital or in home. You have to ask a clear history of the mother. When does the pain start? Whether the pain was regular, whether the pain was increasing. So if the pain was regular and increasing, it means that is the time of onset of true contraction. So you have to note the time correctly, and intensity of contraction, location of discomfort or pain. Usually because the pain starts from the fundus, the mother has to have pain on the upper abdomen. Okay, it is not over the bladder or something. And length of the labor. Okay, so the length, when does from the time of a concept of contraction till now, what is the time? You have to note down the time, so that you can early diagnose whether there is any prolonged labor or something. And number of years since last baby. All this details should be collected. And next is the method of previous delivery, size of the largest or smallest previous baby, expected date of delivery, present week gestation, and absence, presence or increase in blood tissue, presence of vaginal bleeding, membranes ruptured or not, or any prenatal problem. All this history should be collected. Next is a physical examination. You have to do vital signs, temperature, pulse, respiration, and elevated BP or lowered BP. So in order to rule out all this infectious process or infection or shock, anxiety, hypertensive disorder, you have to correctly check the vital signs. Elevated systolic or normal diastolic BP is because of anxiety. Next physical examination is the height and weight. You have to calculate the BMI, and fetal heart sounds, whether it is present or not. If it is present, you have to note it down. It is how many beats per minute. So heart rate 120, below 120 or above 160, we call it as fetal distress. In that case, you have to note it to the physician. Next is a physical examination. In the physical examination, you have to monitor the contraction pattern, which is very, very important. You have to monitor the frequency, duration, and intensity. So, as I told already, you have to place your hand on the abdomen when the mother says that she has pain. At that time, you have to note down the time, and till she has pain, you note down the timing. So that is called the duration. It may last for 10 seconds, 30 or 40 or 50 seconds. So that is the duration. And you don't take the hand and keep it there till the next pain comes. So when the next pain comes, so the time between the first contraction and the second contraction is a frequency. Okay, so now you know the frequency, the duration, and intensity you can say by the mother's response, and also you can say by the touch feel of the uterus. It will be very firm. The uterus will be, the abdomen will be firm like a stone or a cricket ball. Okay, so that firmness refers to the good pain. Okay, but if it is not firm, if the abdomen is very soft, then we can say the contraction is not adequate. It can be a mild contraction. Okay, so that's how we say the intensity, frequency and duration. And next is the engagement. We can do the pelvic grip 1 and grip 2 and can say the engagement, whether the head is engaged or not. An unengaged or unfixed head in primigravida gravida in labor indicates cephalopelvic disproportion. Next, you have to collect the history regarding the estimated fetal weight and fundal height. Fundal height you can measure in inch tape method or with the finger breadth method. Estimated fetal weight you can collect the history from the ultrasound. Okay, smaller than the expected fundal height and the fetal weight, incorrect date or small date. So, if the fundal height is smaller than the expected date, so there may be incorrect date or small for date baby. Larger than the expected fetal weight and the fundal height, so that also can happen if the date was incorrect, okay, or large baby. So if there is large baby, uterine atony and shoulder dystocia can occur. So these are the complications we have to expect when there is a large baby. And next is a physical examination. In this you have to think about the rule out about the lie, presentation, position and the variety. So abnormal lie, presentation or position should be ruled out, and edema of the extremities. So one of the classical sign of preeclampsia, so that is a hypertensive disorder, is the edema of the extremities, and physiological edema is normal. Pelvic examination and vaginal examination should be done in order to rule out the effacement and confirm the abdominal diagnosis. Next, you have to do the pelvic examination for the position of the cervix. The anterior cervix is ready for the labor. If the cervix is very posterior, it means it is not ready for the labor. And to determine the station of the fetal head, you have to do the abdominal examination and find out the station of the fetal head, and whether or not membranes ruptured, amniotic fluid escaping through the cervical os, amniotic fluid pooled in the vagina, or membranes are not felt over the presenting part. With this you can say the membranes are ruptured or not. So next comes the nursing management environment. How the environment should be, it should be comfortable for the mother and it should facilitate prompt and efficient action. So it should have room around the mother to walk around the labor table. It should have enough room and reduce the anxiety. The room should reduce the anxiety of the mother. The labor woman should be welcomed and encouraged in their own surroundings. Emotional support should be given, and if we should display a tolerant and non-judgmental attitude. So whatever the complaints the mother says, you hear her politely and make sure all her requests is carried out. And companion in labor, it can be allowed, okay, according to our local guidelines. And explanation should be done for all the procedures, and privacy is very, very necessary. And prevention of infection. So this is one thing you have to should be followed by all the team members. Okay, mother's well-being during pregnancy and factors affecting resistance like the blood, the nutrition status. So if the blood is having low hemoglobin or the nutritional status is low, the skin and the membranes are dehydrated, the personal hygiene is not good, the mother is not having adequate rest, then it can affect her immunity status. So it means that she can easily get the infection. So all these things should be ruled out. Then the general hygiene, the care of the environment, follow the asepsis and practice everywhere. Restriction of any invasive techniques like vaginal examination is also allowed for after 4 hours. Okay, every 4 hours once only vaginal examination is allowed nowadays. Position and mobility, upright position. This upright position always facilitate efficient contraction and it will shorten the latent phase and reduce the need for analgesia. So we always encourage the mother to have a upright position during the first stage of labor. Okay, only during the first stage but not in the second stage. And during first stage she may rock, walk, kneel or squat in order to progress the dilatation and the effacement. And the recommend position can cause compression of the inferior vena cava and supine hypertension. So lateral position is preferable if she wishes to lie. The other factors governing choice of position or analgesia. So if the analgesia is given, the mother will be unable to walk, and lateral position or can be given, or supported sitting will be suitable. In epidural, analgesia demands woman should be in bed either sitting up or lying on her side. So the analgesia also decides the position of the mother. Next is the monitoring. So the monitoring, how it decides the cardiotograph. If we connect the CTG mission to the mother, it will limit the choice of position. She has to lie down or she has to sit. She cannot walk around with the CTG connected, right? So this also limits the position of the mother. And the fetal condition. So supine hypertension reduces fetal oxygenation. So we always prefer the mother in the left lateral position. And intravenous infusion and complications like APH or OM when the head is high. So all this will restrict the mother's position and to move around. Next comes the nutrition. So advice prior to the admission. So because the woman need energy, encourage the mother to have foods like toast, breakfast, cereal, yogurt, fresh juice, tea, plain biscuits, and clear broth. And fluid should be taken frequently. Okay. And intake in early labor depending upon the hospital. So some obstetrician they will prefer nil per oral, but some obstetrician they will advise the mother to have clear liquid. So it depends on the hospital policy. And glycogenic and fluid requirement should be met, comfort should be given, drink, brushing and mouthwash should be helped. So activities of daily life should be helped for the mother. And bladder care, empty the bladder every 1.5 to 2 hours. Full bladder inhibit the descent of the fetal head, which I said already, and effective uterine contraction. So this full bladder inhibit the whole labor process. So we have to always make sure the bladder is empty, and uterine retention can cause hypertonic uterine action. So because of this, the full bladder, it will affect the third stage also, because of this the uterus will not contract properly during third stage, which sometimes may lead to postpartum hemorrhage. Next is the bowel. Here soap and water enema should be given. So we don't want feces to come during during the second stage of labor when the mother is bearing down. Okay, so the mother will say that she feel like defecating. Okay, it is nothing but the head is hitting onto the rectum and it is bulging out. Okay, so that time she is allowed to bear. We should encourage the mother to bear down, but that time we don't want the feces to come out and to soil the area. Okay, to soil the area of the delivery table and everything. So we always prepare the bowel before the labor. Empty the bowel prevents the soiling of rectum in the second stage of labor. Observation. So these are the observations to be done for mother. How she is reacting to the labor, her vital signs, urinary analysis, fluid balance, progress. Progress in the abdomen, progress in the vaginal examination. So reaction, some women may experience contraction as positive, motivating and life-giving force. Others feel them as pain and resist them. As labor progresses, she may feel less confident. And vital signs, the temperature should be monitored because the pulse rate should be steady. More than 100, it represents infection, ketosis and hemorrhage. Rising pulse represents rupture of the uterus, and record 1 to 2 hours in early labor. Record every 15 to 30 minutes when the labor is more advanced. Pulse should be pyrexia. Okay, pulse should be, if the pulse is increased, it represents, so the previous one is the temperature. If the pulse is increased, it represents pyrexia, and the pyrexia may be due to infection or ketosis, and you should record the pulse every 4 hours or every half an hour as the labor progresses. And blood pressure every 4 hours unless it is abnormal. If the mother has some associated conditions, then you have to monitor the blood pressure every 30 minutes. Hypotension may be because of supine position, shock or epidural analgesia. Next, you have to monitor the urine analysis, test for glucose, ketones and proteins. Ketones may represent vaginal distress, starvation, and proteins represent rupture of membranes, and significant proteinuria may be preeclampsia because of the worsening preeclampsia. It means the hypertensive disorder is going into some complication. Okay, and fluid balance, record of intake output should be recorded. Abdominal examination. Regular abdominal examination should be carried out throughout the labor, and the nature of contraction, intensity, frequency and duration, number of contraction every 10 minutes, and the duration of the contraction should be recorded. So all the things about the contraction should be recorded. And pelvic grip should be carried out. Gradually the rocking of the pelvis, the ballotment should be disappear, and shifting of maximal impulse of FH downwards. So the FH comes downwards as the head comes down. Observations. The fetus, for fetus you will observe the fetal heart rate, fetal blood sampling, amniotic fluid, fetal distress. Okay, so in fetal heart rate there are two types of recording, intermittent and continuous recording. In intermittent recording, the heart rate is recorded using a Pinard stethoscope or a Doppler ultrasound. Okay, the rate should be counted over a minute. Okay, the normal rate is between 120 to 160. The rhythm should be steady. The FHR should be monitored immediately following uterine contractions. So that is very, very important. No recording of the fetal record with the Doppler. Okay, Doppler or Pinard stethoscope during the contraction. Okay, it should be recorded after every contraction. Continuous fetal heart rate is monitored with the help of CTG. Okay, fetal cardiograph, maternal tachograph. There will be two graphs which represents fetal heart rate in relation to the maternal uterine contraction. So observe the response of the fetal heart rate to uterine activity as well as the rate and rhythm. Usually applied for 20 minutes or be used for whole labor. Next is the fetal blood sampling. The normal pH is 7.33 or above. The fetus who become hypoxic will also become acidotic. Okay, it means the pH will reduce. Okay. And amniotic fluid normally clear. Amniotic fluid provides information about the condition of the fetus. If it is green, then we say it is meconium stained. If it is muddy yellow color or slight green, it is previous distress. If it is golden yellow, it represents rhesus isoimmunization, RH isoimmunization. And if it is bleeding, okay, if the color of the amniotic fluid is red, bright red, then there can be we can suspect of rupture of the vasa previa. Vasa previa means the blood vessels which are lying in front of the head. Okay, it may be in the back of membrane, some blood vessels. So the rupture of these blood vessels can cause the amniotic fluid to be in bright red color. And next is the fetal distress. The signs of fetal distress are fetal tachycardia, relation to the oxygen deprivation, fetal bradycardia related to uterine contraction, passage of meconium stained amniotic fluid. So these are the signs of fetal distress. The management will be call a doctor, syntocin drip should be stopped, place the mother in the left lateral position, administer oxygen, prepare for the LSCS. If it is second stage, then liberal episiotomy should be given, and if that is also fails, then you have to extract the baby with vacuum delivery or forceps delivery. So this is how we should act in case of a fetal distress. So next comes active management of the first stage of labor. Here the definition is describe a range of policies which helps to achieve effective uterine contraction, thereby preventing prolonged labor and primary gravity. Active management means we are interfering throughout the first stage of labor to make it fast, to quicken the first stage of labor. Okay, the aim is not to expose anyone with the stress of labor for more than 12 hours. It means we are reducing the duration of the first stage of labor. Components of active management, accurate diagnosis of the labor. So how you diagnose? With the regular rhythmic contraction accompanied by show and rupture of membranes and complete effacement. Then early rupture of membranes can be done 1 hour after the labor is diagnosed, and note the color of the liquor. Okay, so as you said, there are 4 types color can be there, but the normal color should be clear liquid. Monitoring the cervical dilatation effacement should be done. Short for a partogram should be recorded, and continuous professional support for the mother should be given. As I said, what are all the parts you have to take care when you care for the mother in the first stage of labor: the nutrition, the environment, the bladder care, the bowel care, the pain management, the psychological response of the mother, and the metabolism, the electrolyte balance, okay, the hydration status, and the vital signs. signs, how you monitor the mother, how we have to monitor the mother with the her vital signs, the urine analysis of the mother. Okay, and the contraction you have to monitor how well the contraction is for her, and how will you monitor for a baby. The fetal heart rate you have to monitor, the amniotic fluid, and the fetal heart rate can be monitored two types, either with the fetoscope, Pinard's fetoscope, or we can monitor with a Doppler ultrasound or a continuous fetal heart rate monitor like a CTG. So everything should be done monitored quickly, and active management in this we are reducing the first stage of labor to not more than 12 hours. And we are preparing if there is any complications. We will be anticipating any complications, then we prepare for a LSCS, okay, during the first stage of labor itself. So that is about the first stage of labor. In this we saw about the definition, the causes, the signs of the first stage of labor, the stages of the labor, and the physiologic factors, the mechanical factors, the other contributing factors, how to do the initial assessment, how to monitor, how to manage the mother and the fetus if there are any complications arises in the first stage. So these are the things we saw in this video. So I hope you all learned something about the first stage of labor and gained an insight regarding this. So thank you for your kind listening. Thank you, everyone.